Thank you very much, Daryl. I'd like to add my welcome to you all. So the title for this talk I have unashamedly stolen from a report over 10 years ago from Jeannie Brooks Gunn in the US, one of the great colleagues of Greg Duncan. And she wrote in this document, she called this, "Do You Believe in Magic?" And I thought that was a really good theme for me to try to talk about today. What can we expect from early childhood programs? So before getting into that, this conference is a lot about evidence, and evidence-based policy making has become quite common. This particular book about using evidence, which is a good one, says that's because we have a better educated public, a rapid rise in research capacity, information and computer technology, but overall the drive for more accountability for public spending. And that moves with the political times, the idea of accountability, better outcomes with less waste, especially from government spending. That word evidence is an interesting one to me, and something that perhaps we'll explore this afternoon in the Q&A session. So I just went to the Oxford English Dictionary and they give two versions. The available body of facts or information indicating whether a belief or proposition is true or valid. That seems to me a very sort of tight, strict definition that probably aligns well with what we think of as research evidence. But there's also a more flexible notion that it's signs or indications of something. And we can think about how evidence is used in different fields, whether it's in sort of our field with research evidence, but there's also the whole evidence notion that's used in the law. I think we would be naive to not recognise that policymakers and service delivery practitioners must not only take account of research evidence, but also signs and indications from prevailing culture, values, social opinions, influential individuals and organisations, politics and the distribution of power. So it's within that framework that I'm going to talk about research evidence, because that's what I know most about, but I wouldn't be naive enough to think that research evidence actually drives what we see in public policy and practice. It's a much more complicated activity than that. Nevertheless, we are living in an evidence-based culture. And this is perhaps a bit over the top, but it gets across the idea that we are required increasingly to justify what we do on the basis of evidence. In line with that, we've developed a research evidence industry, if you like. There are lots and lots of activities designed to generate the evidence that we require, the evidence we want. And we have an infinite number of policy frameworks, reviews. We even now have reviews of reviews all around this area of child health and development. Let me give you some examples. And these are just the ones that are sitting on the floor of my office. But they all try to get at this idea. This is one from New Zealand, the summary. What we know about what works. And they're all trying to do that in various ways. So I'm going to try to review the evidence as I see it. I guess I'd make the point that I don't think all research is created equal, and I don't think all research reviews are created equal. So I'm going to give you my review for what it's worth, and that's why it's the perspective of one epidemiologist. Now, for those of you excuse me, who don't know what epidemiology is, it's not about skin disorders. So, short and sweet, epidemiology is about describing health states, broadly defined, in populations. Trying to understand what causes those health states and intervening to change them. So we are explicitly and unashamedly about causation. Why? Because we do want to change things. That's the point of what we do. So, epidemiology, why am I qualified to do this? How many of you have seen this slide before? So, epidemiology has been responsible for this. This is the random medical news. We see it every day. The newsreader. Today's news is that coffee can cause depression in twins. And then the next night, the newsreader pushes the button and the 3 wheels spin, and the next night it's avocados can cause heart disease in rats or something. We've had a lot of discussion over the last 20 years in my field about how we get less of this, because it's not helpful. Nevertheless, that still goes on. That's an ongoing struggle. But epidemiology has also brought us to this, which is what we call evidence-based medicine. So in my field of health and medical research, in the last 20 or so years, there's been an enormous rise in evidence-based medicine. Why is that? Because when we treat people, we don't want to do things that first of all hurt them, and we don't want to be doing things that are ineffective, especially when we are spending lots of public money on those things. Now, along with that, there's this list of acronyms down there that I think are important for us to think about in our field of our concerns here. We've developed any number of statements around how research in evidence-based medicine should be done and how it should be reported. And these guidelines, such as CONSORT for randomised control trials, you can't publish in a high-quality medical journal unless you follow those guidelines. And they make statements about what you need to do before the study. You have to register it, say what you're going to do, what your primary outcomes are, and then you have to report against that in a reasonably standardised way so that readers and the public can judge how good the evidence is. So in health and medical care, 30,000 randomised control trials in 2013. That's about 100 a day. We rely on RCTs a lot. Why? Because, like them or not, they generate the best evidence because you've got a reasonable view of causation. Also notice the green line there, which is the rise of synthesis studies, and they're the things like meta-analyses. Obviously at 100 a day, nobody can keep up. It's all you'd ever do, is try to keep up with the literature. So people are summarising that evidence. So my job today is to try to give you a view of that evidence, and I'm going to wander through a review of some of the programs and things that many of you might be aware of. And I've aligned them here according to the age of the children or the parents. So how many of you in the audience know of at least one of those programs? So I don't have time to talk about all of them, but I'm going to wander through some of them. So let's start up here at the beginning. Nurse Family Partnership is the David Oles program. In the UK, that's called Family Nurse Partnership. It's exactly the same program, but they flip the names around. MESH in Australia and Right at Home. So let's get started. I suppose I pondered this. Greg, yesterday, in his very gentle way, gave you a warning, and he said he was going to be grumpy. And Greg's a very understated man, so I suppose in that sense, I might be very grumpy today. So you can't do this without talking about David Oles' Nurse Family Partnership, and I want to run through some of the characteristics of the studies that I'd like to draw out, and out of that I want to sort of try to get some messages. So, the first of the studies, Started in 1978. These are the sorts of numbers in the intervention and control groups, and I'm going to talk about the ends, the sample sizes in this field, and I'll come back to that quite a lot. You notice that by the time they did the second trial, they had almost double the number of people. So by the time you get to 200, most people think that's a pretty reasonably sized study. The kinds of participants that we're looking for, and you'll notice in the first trial that one of the concerns was about teen pregnancy. That was the participants that they were going after. And in the US, that's considered a particular social problem, certainly at that time. I'd point out that teen pregnancy in Australia, the prevalence is 3.5%. It's much, much lower. So if you're targeting that group, you're going after a very small proportion of the births. So just a little bit on the interventions themselves. By control, I guess I should say, does everybody understand what I mean by a randomised study and a quasi-experimental study? Is everybody okay with that? Randomisation means if I was the researcher, I randomly assign the treatment and the dose to the people who are in the trial. Quasi-experimental means they get different interventions and controls, but I don't assign them. They're assigned by some other mechanism. That can sometimes be close to randomisation. So these are properly randomised studies. The control group is screening at 12 and 24 months and normal care. They actually started with 3 interventions, one of which was just free transportation to screening. The second group get intervention 1 plus a nurse during pregnancy, and then the full intervention was all of that plus a nurse visit to home to age 2. That's where we get the idea that they showed that the nurse in pregnancy up to age 2 was the best. That was the best outcome, and that's why we have that system today. And you see that they carry that through to the next trial, but they do the next trial 10 years later in Memphis with low-income African-American women, and they're just testing the nurse from pregnancy to age 2 against the control. And then the Denver trial takes that forward again and tests that nurse pregnancy and postnatally against a paraprofessional visiting doing the same thing to see if it required a nurse, because nurses are more expensive, and they found that the nurses did better. The dose of the trials. So you'll see in Elmira across all of the trials, there's about 30 visits in total, with 9, 7, something like that, antenatally, and then the others delivered postnatally. Now remember in Australia that the average number of antenatal visits is about 7. They're not home visits, but they are contact with the health system, is about 7. So we're already at that level that was being tested here. The visits are about 75 to 90 minutes duration, cost about $11,000 per child. Okay, so what did they find? I'm going to talk about the consistent effects. And the reason is because you get lots of different effects in different studies. They don't even stand up within the same study over time. And I'm going to make another point about that a little later. These are the consistent effects across 2 or 3 of the trials up to age 15. The arrows up mean increase, the arrows down mean decrease. So you see it's actually not a terribly large number of outcomes that are consistent across the trials. So a little background on Elmira. They first started looking in high-risk groups. Understandably, women who were smoking in pregnancy, those who had low birth weight, etc. Then increasingly they started to focus on poor unmarried teens, which is about 23% of the population. And this is in their analysis. They're sort of looking for subgroups where the effects were larger. And that's fair enough. In the early days, that's a perfectly good thing to do because you're trying to find out who does it work for. This later became investigation in subgroups of those with low psychosocial resources, and you see that language still today. That was described as low IQ, mental health problems, and low self-efficacy. So many of the strongest effects that were reported in various literatures around this were among this subgroup. They were apparently pre-planned, but the trials were never powered to look at those subgroups, and I'll talk about power later. By power, I mean the size of the study, the N, if you like. That tradition of low psychosocial resources has continued on to the present day, and you see when Lynn Kemp published her study, she reported effects in these subgroups. So my first message, RCTs are really expensive to run, so we better power them properly. And that means having large enough sample sizes that we can reliably estimate the effects on the things we think our program will affect. Message one. All right, let's follow up Elmira. We go to age 19. At that time, there were no effects of the program in males. There were only effects in females, and they were related to the number of lifetime arrests. The intervention effect was about 0.5 of an arrest over lifetime, and decreased convictions. No effects on high school, workforce participation, number of sexual partners, birth control or teen pregnancy, welfare use or Medicaid. Let's explore a little deeper. What's the community context of Elmira, New York? Now, I'm sure most of you have no idea where Elmira, New York is. It's about a 40-minute drive from Ithaca, where the great Cornell University is. And that's where David Olds did his PhD with a fellow called Yuri Bronfenbrenner. How many of you know that name? Small world. Any of you who have ever used that sort of diagram where the child's at the centre and surrounded by the various layers? That's Bronfenbrenner. In 1980, the trial started in 1978. In 1980, Elmira was rated the worst metro area in the US for economic conditions. From 1980 to 2010, population lost 21%, with over those 3 decades unemployment running at around 12%. The current median income is about 30% below the US average. Median house price, $80,000. New York State average is $3,300. The message 2, local context can severely constrain early intervention effects on long-term outcomes. Why would we think that a program that operates from pregnancy through to age 2 is going to have a long-term effect when those kids go to poor childcare, poor preschool, underfunded schools, and then go into an employment environment that's severely constrained? Nobody would believe that. So I think we do need to understand the context and the continuity that's required to keep those effects going. All right, we'll turn to Australia. MESH. This is the Miller Early Childhood Sustained Home Visiting Program. Miller's part of an area near Liverpool in Sydney. So let's do the same thing. 2003, 2005, about 10 years ago. Again, look at the size of the study, relatively small. These are the participants. That sort of has expanded now. So we've got multiple characteristics that they're trying to get to. So it's 1 or more of being under 19, Edinburgh Depression scale up, lack of social support, etc., etc. And about 80% of the participants had 1 or 2 of these. So here's the information about the trial. A couple of things to look at. The dose was 16.3 visits. That's about half of nurse-family partnership. And that's because about half dropped out by age 1. It's very difficult to retain people in these sorts of programs over time. This is a very well done trial and every effort was made. This is not because people weren't trying hard. It's very difficult to retain people in such trials. They examined about 20 outcomes at age 2. Most effects are in the right direction, but the only main effects, by that I mean the effects between intervention and control as a whole, were related to the home inventory, responsiveness of the mother, and this very large effect on breastfeeding duration. That's an enormous effect on breastfeeding. They also presented evidence that the effects were greater among those with low psychosocial resources. So what you do then is you split up the analysis and you look at those with low psychosocial resources versus without. That's what I mean by a subgroup analysis. The trial was never powered to do that, and they sort of focus on some of those in the report, but what they're really doing, if you look across all of them, is they're kind of cherry picking out the good ones, out of here and out of here and out of here. So if you're not really aware of that, you start to think that there is all of these effects that I would say positive effects can be modest in scope and size, despite what is sometimes claimed from subgroup analyses. So beware the subgroup analysis. It doesn't mean that they're wrong, it just means that they can be very unreliably estimated, and you could go do it again and get a completely different set of answers. So this is the Right at Home trial being conducted in Victoria and Tasmania as we speak. They're now collecting the 18 and 24-month outcomes, and they are going to report their findings in 2017. And you'll notice right at home the N is about 700, so this is a large study. The Victorian government announced just this year, not so long ago, that they will invest $30 million in a new intensive home visiting program. The trial hasn't even reported yet. Okay, Sure Start Centres, I put that in there because that's a centre-based program that's received a lot of political support in the UK. There's been a lot of money invested in this initially. Now it's been chucked over to the local authorities and they're having to close them because they can't afford to run them. But nevertheless, they've had some positive findings out of that through a quasi-experimental design. Let me move on to what we might think of as the big three. These are pulled out a lot: Abecedarian, Peri and Head Start. And I'll talk about the first two. So for those of you who didn't know, and I didn't know what an Abecedarian was, it just means it's somebody who's learning the alphabet. Who knew? 1972, we're in North Carolina. Look at the size of the study. So this, by any stretch of the imagination, is quite small. And it's targeting very low-income African Americans. The mean age of enrolment of the child is about 6 to 9 months. So I draw your attention to the dose. 8 hours a day, 5 days a week, for 50 weeks, from 6 to 9 months to age 5, with a subset going to age 8. That's a very intensive intervention. And the ratios for staffing, the child-teacher ratios, 3 to 1 in infancy and 5 to 1 for the 5-year-olds. Average cost? Not surprising. It's an extremely intensive program with very well-trained people running it. But I'll draw your attention to this. As of January 16, these are the ASEQA guidelines for staffing ratios in Australia. They're not far off what the treatment did in Abecedarian. In other words, we already have standards of care, usual care, that are approaching, in some ways, the things that were trialled in interventions. And that's another theme we'll come back to. We need to be aware of the context within which we try to get these effects. What did they find? Outcomes through age 21, increases in IQ, academic achievement and test scores, no effects on criminal activity like they found in Elmira. And the preschool program, having the preschool plus the age 8 was more effective than just having the school age program. They published many things, but I'm picking out the health outcomes at age 21. Not much going on, actually, if you look at this paper in the American Journal of Public Health. By the time they get to 40, there is this famous publication that was put into Science a couple of years ago that's been much cited. And the biggest effect in that is an effect on blood pressure of 17 millimetres of mercury. Now, is that important? Well, my colleagues in cardiovascular epidemiology would say, wow, because if you use a drug, and there are highly effective antihypertensive medications, they generate an effect of about 9 millimetres of mercury. So the effect of this intervention is twice as good as those. That's hard to understand. But it is the data. The data is what it is. But again, it's coming from a very small study, and this particular follow-up involved about 21 people out of the 57. When you start to get down to those ends, you will generate these sort of random large effects from very small studies. Nevertheless, the data is what it is. They're not doing any tricks with it, but it's very hard to understand how that works when an agent that directly affects the biology of blood pressure has half that effect. All right, high scope, preschool. Ypsilanti, Michigan, 62 to 67. So this is quite early. And again, a very small study targeting low income, and they start at 3.5. Abecedarians start 6 to 9 months. They're starting much later, at age 3.5. And interestingly, I've been reading some of the very early studies, the early reports of these things. And I came across a report by David Weikert, he ran the program through the Ypsilanti School District. And it was conceptualised as a compensatory education program. That's what it was meant to be for what he described as functionally retarded, disadvantaged children. So let's have a look at the dose. 2.5 hours, 5 days a week, 30 weeks, plus 1.5 hour home visiting up to age 5. Again, low child-teacher ratios, highly trained, cost about $18,000 per child. What did they find? Up to age 40, we've got better test scores, less criminal activity, earnings, less welfare, less smoking and alcohol. Large effects on IQ, but they fade out by age 7, and that's something that many people have tried to interpret, and this is the sort of graph that they use. So that's abecedarian on top, where you see the red and the blue as the intervention control. You can see the red-blue difference in abecedarian fades a little bit, but it's still there, whereas in peri, you get this large spike in IQ early on, but by 7 it fades away. And people like James Heckman, the economist, have interpreted that to mean that they still get these long-run effects in peri, but it's not going through IQ, is the interpretation. Therefore, it could be what we loosely and incorrectly, I suppose, call non-cognitive skills. Everything's cognitive, but this group of skills that we talk about as self-regulatory abilities, resilience, grit, attention, perseverance, these kinds of almost personality characteristics that also are related to success. I mean, we all know to be successful in life, you don't have to be the highest IQ person. There's a lot of things about you just show up and you work hard, and that does a lot. So there are other things that predict success. Anyway, this is where we start to get into the non-cognitive idea. Now, this is a very, very important paper authored by the man who's sitting in the audience here, and Catherine Magnuson. If you've not read this, you should. It's an essential read, I think. And in this paper, Greg's looking at cognitive or academic achievement. And there's 3 things I'd like you to think about. So if we have a look at these studies, there's peri up the top, the peri preschool, with an effect size of 1.1. You see that it's sort of an outlier on the top side. The first thing to me is the enormous variation in effects that are occurring in these studies in the 60s, because they're still sort of figuring out what's the right way to do this. But you get all kinds of effects through there. The second thing is the general decline in those effects over the 40 years that are being spanned by Greg and Catherine's study. Why are the effect sizes going down over time, on average? By the time we get down here, they're all kind of hovering. You see the studies get bigger. The size of the circle is proportional to the size of the study. So the studies get bigger, but they're all sort of hovering down in between null and sort of 0.2. So we could speculate as to why that happens. I think one plausible idea is that the control conditions are changing. In other words, what we implement into society when we We change, we become, I suppose, more socially justice oriented, and we start to have better services to support disadvantaged people. The safety nets start to rise up and they get wider and better, and that's what I mean by usual care. The control conditions change. So that's one way of thinking about these. For my message, exceptions are not rules, and that's clearly evident from this graph. Peri and Abecedarian are exceptions. All right, let me go to a couple of more recent reports now, and I want to talk about 3 of them. The first 2 are RCTs, and then I want to say some things about triple P. So the first one here is the Family Nurse Partnership. This is the large 823 women in intervention and 822 in usual care. So this is a very large trial. They reported, this is a trial of the David Olds Nurse Family Partnership in the UK. They reported in Lancet in 2016, and I was asked by Lancet to be one of the reviewers of this paper. And I think it's almost the only time I've ever sent a review back where the first thing I wrote was, I have absolutely nothing to add. This was really well done. They looked at everything. And so this is a very reliable piece of evidence. What did they find? You can read that for yourself. They were bold enough to actually come out and say program continuation is not justified on the basis of this evidence. As far as I know, it's still being rolled out in the UK. But again, it brings home that point. Control or comparison conditions matter. 21st century UK, usual care, there is a large network of existing services that are there. It's very hard to find effects against that background of, I'm not saying they couldn't be better, but they're much better than they were in the 60s or 70s and in other countries. Nevertheless, this is the same program done in the Netherlands. Their outcome here is child maltreatment, and again, recently reported in 2015. So, notice again, it's a fairly small study. Have a look at the dose. That's 1 visit at home every 2.5 weeks. Again, that's a high intensity intervention, and it may well be worth it because they do find that you get an 8% difference in child maltreatment reports between the intervention control, but nevertheless, a very intensive intervention. Okay, I want to talk about the Preparing for Life trial in Ireland. This again was a very well funded by philanthropy, trial in Ireland that had a low support group. See the ends up there, 118, pretty good. A high support group, 115 control. And the high support group had a trained mentor. This is back to the idea of a paraprofessional and not a nurse. So this is sort of like a mentor that you have who's trained, but not the nurse, as in the David Olds type programs. And they had parent training with triple P. So they've reported up to 36 months, and my read is there's very limited effects at any age, all the way up to age 3. The triple P subgroup is way too small to say anything sensible about its effect. And again, we run into this problem of small numbers. So I want to pick this out as another potential message. This is the way they're reporting their results. So this is the proportion of measures, in other words, the number of things they've looked at as outcomes that are significantly different. And they do that from 6 months all the way across, 12 months all the way through to 36 months out there. And they do it across these different domains of outcome, if you like. Child development, child health, etc., and parenting. Now, this is probably the grumpiest thing I'm going to say, but it's hard for me to think of almost a less informative way of presenting results of trials. This doesn't tell you very much, and it It knocks into this problem we have of using statistically significant yes, no. That's got to go. It's not a helpful tool. Everybody's saying that. We've got to stop doing that. Because it generates this kind of statement, and you read through it, and the conclusion is that something around 20 to 25% of the outcomes, and they're looking at 240 different outcomes, and a quarter of them show statistically significant differences. I have no idea what that means. So, message number 6. Reporting of intervention studies in this field is well below the accepted standards in health and medical research. You tried to publish this in a leading medical journal, you wouldn't even get reviewed. We need effect sizes, and we need measures of uncertainty around those effect sizes and full reporting of the pattern of findings. Okay, so let's talk about Triple P. This is off the Triple P website under evidence, and it says the evidence, it comprises more than 580 published papers, more than 200 evaluation studies, of which more than 100 are randomised control trials. At the same time, we see these things appearing in the literature. So this was a PRISMA systematic review. Under the PRISMA is the reporting guidelines for systematic reviews in health and medical research, and a meta-analysis of Triple P. They say that we should be applying the same standards used in assessing pharmaceutical interventions applied to social interventions. It's an interesting topic that we probably should talk more about. A commentary that came along a little bit later. The most serious problem with the Triple P literature is the over-reliance on positive but substantially underpowered trials. Why does power matter? It means that in small studies you're much more likely to get large effects, and they'll bounce around all over the place in different studies. It's very hard to draw conclusions. The trials have to be adequately powered to do this kind of thing. So in response to that, this paper came out in the Clinical Psych Review, and it is a systematic review and meta-analysis that included 101 studies. And interestingly, they combine in the meta-analysis the randomised studies and the observational studies into one and get their meta-analytic effect by mixing them up. I don't understand how you would interpret that, but that's what they did. So what I did was go through this big supplement of all the studies. 76 of those studies were randomised controlled trials, cluster randomised trials, or quasi-experimental, with an average Triple P level of 3.8. Triple P has different levels from the population base through to the more intensive ones. So the average level of these trials is 3.8, which is the higher intensity kind of Triple P. 75% of all of those trials were smaller than 120. That means less than 60 per group. 3/4 of them are at the level of preschool in terms of the size of the trials. There's only 3 large population studies. The first one Steve Zubrick did in Western Australia, which was a quasi-experimental, where you have areas that get Triple P and areas that don't. And the difficulty is the areas are different in lots of ways, and trying to get them to be a close match is really hard. And Steve and his team did a fantastic job in trying to do that. But in the end, you couldn't get rid of those differences. And they said, well, we can't really tell. And then Matt Sanders did one in Brisbane, the same problem. The most famous one in this field is the study by Prins that is often used in terms of evidence for child maltreatment. It's a cluster randomised trial where you've got 9 intervention and 9 control counties in South Carolina, and they reported strong effects of Triple P. That study was criticised because of the way the trial was reported. They did some interesting things with the analysis that various people have written about, and I didn't understand why they would analyse the data. They did. Anyway, it's now been reanalysed and just published recently in 2016 according to what the critics were asking for, and the effect remains. Important to understand, though, that it's not an effect of reduction in child maltreatment. In the intervention communities, child maltreatment stays the same. In the control conditions, child maltreatment goes up. Nevertheless, that is the data and that is the finding, and it seems robust. It makes me wonder, though, if you look through this literature and you try to understand for triple P, the level 4 triple P, the penetration of the intervention into the population is at best 10%. In other words, 10% of the target population actually get any level 4 triple P. So it is astounding to me that something that has such low penetration into the target population generates such large effects. I don't understand how that works. I think Matt would say that there's a social contagion process going on there, which it may well be. But we need to think about how that actually would work when the people you're trying to get to don't get the program. Message 7, question overstated evidence. These are overstated evidence claims in my view, and I think we need to be aware of when evidence claims sort of go beyond the bounds of what's fair, as a fair reading of it. Okay, I was delighted that Greg yesterday brought up home VE, because independently, Greg and I did not put our heads together for this at all. He decided to have a look at this. 3 minutes, you're kidding. Ish. Okay. I better go fast then. But we've got coffee, so we can go into that. All right, I'm moving quickly. As part of Obamacare, the effort to get healthcare to everybody in the US, there's a movement called comparative effectiveness research. And basically it's trying to drive health and medical research to say, here's one way of doing something, here's another treatment, let's figure out what the best one is and we'll pay for that one. And we do that in Australia. So as part of that, there was $1.5 billion set aside to states for home visiting programs. And they decided that you better put in evidence-based programs. And so that's what this system was set up to do. So these are the model reports. You can have a look at this website. It's great. It's really well done. It's really rigorously done. So if you want to know things about various programs, I would recommend this. It's the best I've seen. Okay, so here's the 19 supported programs. There's the 25 not supported. Not surprisingly, we've got Nurse-Family Partnership with fully 21 studies, 19 studies for Healthy Families America. There's MESH, Triple P over here on the not supported side. Of 44 home visiting programs out there, only 19 were supported by evidence, 43%. Of the 231 eligible studies, only 42% of them were high to moderate quality. So that makes me ask, why is it that less than 50% of the research evidence involving home visits is high to moderate quality? We need to do better than that. It's just a waste. Why do these studies that can't tell us very much? Okay, coming back, this is a report from David Oles, and he's been very good at the way he reports his studies, I think. This is an example. He says, these are the things we improved, and these are the things we didn't improve. And this is what Greg was talking about yesterday. What's the denominator? So I made my own spreadsheets and went into this database. So what you've got here is the developmental domains down the right-hand side that they looked at, and then the green is where you had it as a primary outcome and a positive effect, a primary outcome and no effect, a secondary outcome positive, and a secondary outcome no effect. Let's have a look. So child development would be an obvious thing to target. It was studied 59 times with 5 positive effects And I'll just flip through these. You can get an idea of what it looks like. So this is nurse-family partnership. Nearly 70% of the studies are high quality. That's why it is the best evidence-based program. Positive effects on primary outcomes, 15%. Negative on secondary, 14%. Here's Healthy Families America. I'm going to just skip through these. You'll get the idea. Story's the same. 37% high moderate quality. Positive effects on primary outcomes, 8%. MESH. 100%, it's only 2 studies, 7% on primary outcomes. HIPPY, 12% of studies, high moderate quality, 13% primary outcome. Why is the research evidence quality so low in some cases? 19 out of 44 home visiting programs, high to moderate quality. What do we make of the fact that we're only getting 15% of the outcomes on positive effects? Evidence reviews and policy frameworks invariably tell the positive effects. So this is the way Aracey describes the nurse-family partnership, and you look at that laundry list, that's actually cherry-picking out of the various studies the positive effects. No denominator. For nurse-family partnership, they're only hitting 15% of their primary outcomes. This is the way the Australia Futures Project describes HIPPY. $100 million committed to HIPPY to support the ongoing program delivery, blah, blah, blah. Only 12% of HIPPY studies high to moderate quality. AIF's own quasi-experimental evaluation, at best, showed very limited effects. We've just completed a systematic review of non-cognitive characteristics, self-regulatory abilities. This has occupied the last 2 years. These things are enormously time-intensive to do. Started out with nearly 10,000 papers. You come down to 375 that are eligible. So this is non-cognitive self-regulatory abilities measured under age 8 on academic achievement, language and cognitive and psychosocial outcomes. What I want to draw out of that for you is that we rated the evidence fairly rigorously, but generously. Only 38% of that is better evidence in our better evidence category. So 2 out of 3 of all the publications on the quantitative effects of self-regulatory abilities on those outcomes has little to say in terms of contributing to the research evidence. That seems an enormous waste of effort, and researchers have to do better. Why? Because we're not dealing with systematic error. And again, I picked out this report as well that Greg did. And here's what the Harvard Center on the Developing Child is saying. And this is straightforward. The widespread preference for evidence-based programs, many of which have produced small effects on random categories of outcomes that have not been replicated. That's pretty direct language. That seriously limits the ability of achieving increasingly large impacts at scale over time. That's meant to be a joke. It's a light-hearted moment. So we might need a restock, otherwise we're going to have a couple of tins of spaghetti and some potatoes that are going a bit mouldy. I added in angry down the bottom. I'm prepared for that. Okay, so Jack Shonkoff, as usual, telling us good ideas about how to move forward. I like his idea of constructive dissatisfaction, and I hope that's a discussion we can have today. It has to be constructive because we all want to do better. But it's going to have to be a dissatisfaction, I think. Most importantly, let's learn from things that don't work. That is tremendously hard to do, because there's many drivers that tell us not to do that. The sad thing is, we said the same thing 10 years ago. This was something that Mark Chaffin wrote in Child Abuse and Neglect about the lack of evidence about programs to reduce child maltreatment. He wrote this commentary, and then there was all this backwards and forwards, and Jack Shonkoff said basically the same thing, and that was over 10 years ago. Are we doing this again in another 10 years where we sort of say, oh, geez, we need to do better? Okay. Again, the perspective of one epidemiologist, and Daryl's getting very nervous down there, but I'm winding up. So the messages. Let's power RCTs appropriately. They're really expensive. That's especially true if the theory suggests effects in particular groups. I see Leonie sitting here. Her Milbank paper, if you've not read that, is a must read about the importance of theory and program logic. Use it. If you believe your program's going to affect some things in some groups, then power the trials to do that. Local context. Positive effects are modest, beware the subgroup analysis. Exceptions are not rules. Control conditions matter a lot. Question overstated evidence claims. We can do much better in the way we report trials in this field. And less than 50% of the research effort can really help us know very much. That's a big challenge to the researchers. All right. We will need to develop new silver bullet programs. We will have to do that, and that will take a lot of hard work in developing the interventions. And then we've got to test them in well-designed and powered RCTs that explore dose. You saw the dose effects of these very intensive programs. It's hard to imagine how we'd do that in standard service delivery, although in some cases we are, but we need to have a conversation about dose and the evidence related to dose. I think they need to have real integration with existing systems, existing services and information systems across sectors: health, childcare, preschool, education, child protection. Perhaps, I think even more importantly, we need to develop well-planned, well-resourced and iterative enhancements to existing services. Innovation is going on out there every day. Practitioners are changing the way they work, and we miss that. That's what's improving usual care. We need to get a much better handle on the innovation that's actually happening within service delivery. These are enhancements to usual care that can be routinely, rapidly and cost-effectively evaluated. And I think this is where we need to have a discussion about good use of administrative data. We collect lots of administrative data and we're not using it for those purposes yet, but we could. Oh, good enough evidence. We don't need a randomised controlled trial of everything. What we need is good enough evidence. And that means understanding how close our quasi-experiments can get to randomised conditions, and that will provide good enough evidence, especially if it's located within existing service systems. This is an example from New Zealand using administrative data entirely, where they've evaluated a family home visiting program. That's good enough. That's probably good enough. And this is cheap. This is using the data that's already collected. This is highly cost effective, it's rapid, we've got to get better at using it. Okay, usual thing, evaluation, let's not make it the afterthought. We spend 5% on the evaluation and lots on the intervention. I'd also like us to think about the idea of, instead of evidence-based practice, practice-based evidence. Innovation is occurring in practice every day. Let's figure out ways in partnerships with academia to use those innovations that we want to plan them and utilise them to get a better handle on innovation and effects. So turn it on its head. Instead of having trials out here and then we translate the evidence in, let's do it in here. Practice-based evidence. And it can be done, and there are some good examples of it. That, however, has major implications for the information we collect and the IT systems. I'm working with child and family health nurses, and I think they're using Windows 95 on their computers. Okay, that's what our Empower CRE is trying to do. This is a collaboration across many disciplines. It's in the health system because that's where we work, but it involves pragmatic RCTs and co-creating natural experiments. We also do a lot of data linkage. We have a major data linkage project in South Australia that has information on 300,000 people and a vast array of administrative data now, plus clever cohort simulations. So we do trials in the antenatal and postnatal system, and we follow their effects through data linkage for medium term and then simulations into long-term outcomes using cohort studies. The problem's not gone away. We do need to mitigate the effects of early life disadvantage. Australia needs its own investment evidence base because our context of usual care is very different to other countries. I think we should connect it to the whole human capability formation agenda. I think that can be a healthy thing for us. But it must be intimately connected with existing services. And we should develop practice-based evidence. So, I'm finishing up. Implications. For the researchers, we can do better. Why are more than half our research outputs in this field not very useful? Research funding agencies, they need to be much better at actively managing the portfolios. It's 1,000 flowers bloom. One year, something pops up and it gets funded and we'll have $2 million over there. And then 2 years later, a very similar thing pops up over here and we'll fund that as well. And there's absolutely no corporate memory around the investments. Program commissioners need to get a bit more savvy about what we mean by evidence and what standards of evidence we need. Managers of practice, implementation, attention to implementation and quality control, and we have to engage frontline staff who understand that they're valuable in terms of helping innovate and the information we collect has meaning for them. Apparently, we care more about the quality of our coffee than we do about the quality of our childcare. Oversight. Who's in charge? We're all over the place. We've got something going on in Queensland, and then there's something over here, and the feds throw a bit of money over there, and the state does something here, but they're already doing that in another department. Who's in charge? I don't know. Let me finish with this. Do we believe in magic? This is Ed Zigler, so widely regarded as the father of Head Start. And he did a trial in 1968 on motivational aspects. And he said that these changes in IQ weren't about IQ, they were about motivational factors. Maybe he was the one that started the idea of the importance of non-cognitive factors. But he wrote the closing to Jean Brooks' Gun, Do You Believe in Magic? And he said 40 years of believing in magic is enough. And here's what he said. Are we sure there's no magic potion that will push poor children into the ranks of the middle class? Only if the potion contains healthcare, childcare, good housing, sufficient income for every family, child-rearing environments, free of drugs and violence, support for all parents in their roles, and equal education for all students in schools. Without these necessities, only magic will make that happen.